Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.
All right, welcome back. Today we're going to be talking about sepsis again. Yes, part of our sepsis series. What have we done so far? Sepsis basics, septic shock basics, septic shock pathophysiology, sepsis-induced cardiomyopathy. And today we're going to be talking about one of our nerdy pleasures, which is sepsis phenotypes. This is a more advanced, episode, although certainly lots of things that are just interesting for anybody who has a curiosity about sepsis, and then maybe has some more clinical applicability for those of us that work in healthcare. For those of you listening to this as a podcast, we will link the YouTube video in the description. For those of you watching the YouTube video, we'll link the podcast in the description. We also have a Patreon page that will upload the study guide as well as practice questions, and then a free weekly newsletter. Again, all that linked below if anyone has an interest in those things. No further ado, sepsis phenotypes. Why phenotype sepsis? Well, sepsis in general, as we've talked about, it's more of an umbrella term for a syndrome, okay? People get an infection, and that infection leads to a dysregulated host immune response. And that dysregulated immune response causes a number of downstream things, right? Cytokine release, endothelial injury, microvascular thrombi, adrenal suppression, mitochondrial dysfunction, vasodilation, possibly sepsis-induced cardiomyopathy, but all patients act a little bit different. Right? Not every patient with sepsis looks the same. And what we're starting to learn as we start to understand sepsis and really medicine in general is that precision medicine is really important because patients react different from one another. Not everyone is going to react the same if you were to give them a similar kind of clinical problem. Not everybody with pneumonia has this exact similar course, right? Some are totally fine, and then some are critically ill, and some pass away. So that's why we phenotype sepsis, because it seems like there are probably different quote-unquote subtypes of sepsis that affect people. All right, so sepsis is a heterogeneous syndrome with diverse presentations and outcomes. Clinical trials on sepsis have often failed to find a benefit. And one of the theories, although we don't know for sure, but one of the theories is that we're kind of lumping all patients with sepsis together, and then we're doing this intervention. And those patients with sepsis, again, are probably all slightly different, so that intervention doesn't show a benefit. But would it have shown a benefit if we only chose a specific subtype, a specific phenotype of sepsis, and tested that intervention just to that sepsis phenotype? We don't know the answer to that question, but the curiosity is, well, maybe it would have. So when we try to phenotype sepsis, the goal is to improve risk stratification, guide therapy, and enable precision medicine. The easiest thing to compare this to in your mind is cancer, right? It's not just lung cancer. There's multiple different types of lung cancer, right? Maybe it is small cell lung cancer, but it's not just small cell lung cancer. It is small cell lung cancer with this genetic profile. And if we were to test these treatments for this very specific genetic profile of small cell lung cancer for all patients with any generic lung cancer, that intervention may not show benefit, but it does have a benefit against this subtype of lung cancer. Okay, and sepsis might be similar to that. So this is a very new, we shouldn't say that, this is new-ish. There's lots of additional study on it currently. People have been looking at this for quite some time, but it's come under the spotlight a little bit more, sepsis phenotyping, particularly guided by how much we're starting to realize that cancer phenotyping or cancer subtypes is incredibly important to guide treatment, and that maybe other conditions like sepsis or acute respiratory distress syndrome or any of those are similar in terms of subtyping or phenotyping being important. So part of this comes to a big trial that came out recently in 2019, okay? And it was by Seymour et al. Published in JAMA, and we'll put the citation at the bottom of the video. This is from the trial. It's kind of their work. But there's been lots of different trials on phenotyping in sepsis. and many of them look at different things like biomarkers or cellular, different immune cell activation or different clinical features. This one by Seymour et al., one of the reasons we enjoy it is because it looked at clinical features, and only the clinical things you could garner from, we believe it was within the first 12 hours of presentation. So these are things that everybody should have access to in the clinical arena, and things that you should have access to early in the course. And they looked at a ton of patients, okay, almost 64,000 adult patients with sepsis. Now it was retrospective. They did look back in time using the electronic health record and used machine learning. This is outside of our area of expertise or understanding, so we can't really comment on how robust this is, but they have this kind of incredible machine learning approach to this retrospective chart review. They then found 29 routinely available clinical variables. Oh, from the first 6 hours. We said 12 above. It was even less than that. First 6 hours in the ED. And then they looked at these variables to try to validate if there was distinct clinical phenotypes of these sepsis patients. So they used kind of complex, again, above our level of understanding algorithms to see if there was clusters of variables that would represent specific phenotypes of sepsis in these patients. And what they found was that there seemed to be 4 different sepsis phenotypes. Now, caveat to all this, this is based on one trial, okay? Take all this with a grain of salt. Don't take this and run with it as if it's absolute fact. This is very, very early days for this kind of stuff. But they did identify 4 different phenotypes, and they called them alpha, beta, gamma, and delta. And they acted a little different. So the alpha phenotype was often younger patients, less comorbid illness, so less patients with diabetes and hypertension and cancer and heart disease, and usually their illness was mild. And what they found is that alpha phenotype, their mortality was 5%, so the lowest of the 4. There was then a beta phenotype. These patients were often older in age, had more comorbidities, and often had renal injury from their sepsis. Their kidneys were injured. And the mortality in this group was about 13%, so a little higher than alpha. Gamma had a higher degree of inflammation. Their inflammatory markers were kind of more elevated and deranged. And they also had a higher incidence of pulmonary dysfunction or lung dysfunction requiring oxygen therapies or mechanical ventilation. Their mortality was a little higher, but similar-ish to beta. So kind of this beta and gamma phenotype mortalities were similar, whereas alpha was the lowest. And then delta were the sickest patients. These were patients in shock requiring vasopressors. They had a lot of liver dysfunction, a lot of coagulopathy, or kind of microthrombi, blood clotting, bleeding derangement. And the mortality was the highest. It was about 33%. Okay, and they found that these phenotypes for them were repeatable. They could identify within those patients with sepsis that they were studying which one was alpha, beta, gamma, or delta. If we were to describe these a little bit more, because we think this is important, that the alpha phenotype, if we were to describe it more, again, were younger patients. They did not have a lot of organ dysfunction. They often weren't in shock, and they had a really good prognosis. They responded well to standard care, fluids and antibiotics. Antibiotics, ABX antibiotics. The beta, and remember, the mortality rate for alpha was about 5%. The beta phenotype, this was an older population, a geriatric population, and they had a lot of chronic comorbidities, chronic kidney disease, heart failure, heart disease, hypertension, diabetes, all that kind of stuff. And the dominant organ system that was injured was the kidneys. A lot of these patients had acute kidney injury and acute renal failure, okay? They had a higher frailty, they were older at baseline, and the mortality that they saw in these patients was often driven by their pre-existing diseases rather than kind of their quote-unquote sepsis in general. And their mortality, as we said, was 13%. Nope, up here, 13% for the beta phenotype. Okay, and then the gamma phenotype, these patients had a lot of inflammatory derangements. So they had high WBCs, high bands, high inflammatory markers. And their predominant organ system involved was lungs, respiratory failure. They'd have pneumonia or acute respiratory distress syndrome. Many of them required ventilatory support early. And these were patients that maybe benefited from more immunomodulatory therapies. Again, we'll need future trials. And their mortality was similar to the beta phenotype at 15%. Okay, but starting to see how these are a little different, right? These ones was more hyperinflammatory, more respiratory failure, more ventilatory support, whereas this one was more older, comorbid, renal dysfunction. A lot of their disease was driven by their pre-existing disease. And this one was young, healthy, not a lot of organ dysfunction, really good prognosis, just classical therapies. Then the Delta phenotype, again, this was the highest mortality phenotype. These were the patients in shock. They had hypotension, high lactates, high SOFA scores. They had a liver dysfunction, high INRs, which is that kind of coagulopathy. They had an acidosis, metabolic acidosis, and they were the highest mortality, right? Their mortality was around 33%. Rapid decompensation was common. These were the sickest of the sick. And those of you that work in the clinical arena, you might recall kind of seeing these phenotypes, right? That patient who is really doing totally fine. They got sepsis, but they're going to be okay. Give them traditional therapies, they get better. Or that beta phenotype, which is kind of that older, frail, comorbid patient who's got kind of acute kidney injury and has got sepsis, and their progression of disease, if it does get worse, seems to be more so related to their chronic comorbidities. Or that gamma phenotype that's got that white count that's through the roof. Their inflammatory markers are high. They require early mechanical ventilation from things like pneumonia and respiratory failure. And then that delta phenotype, that multi-pressor refractory shock, their lactates through the roof, they got liver injury, coagulopathy, acidosis, they're on multiple vasopressors, they often unfortunately succumb to their illness. Right? These are phenotypes that it seems like anecdotally we have seen. So the clinical application here is that one might help with risk stratification. We know that the Delta phenotype has the highest risk, the highest mortality. Okay, they might need closer monitoring, earlier escalation of care to something like an intensive care unit. Tailored therapies is a really exciting future thing. There's not enough evidence right now to support tailoring therapies, but we should probably study therapies for the different phenotypes. There's some early evidence that maybe the gamma phenotype might benefit from anti-inflammatory modulators. The delta phenotype, with all that coagulopathy, may benefit from things like anticoagulants, right? They might have more microthrombi. Trial design is a future importance. Maybe you stratify by phenotype to clarify which subgroups might benefit from therapy. And then there's some discussion on resource allocation, but probably not a big thing for this discussion. But our most excitement with things like phenotyping is, could we tailor therapies, right? Do these act different when it comes to different therapies? Maybe one wants less fluid, one wants more fluids. Maybe one benefits more from steroids and one doesn't, right? Maybe one benefits from early mechanical ventilation and one doesn't. All these things are really interesting questions that might have different answers than has been classically discovered if we were to think about these interventions based on the phenotype that the patient is presenting with. We do have just a couple clinical vignettes to apply the phenotypes. This is just something that we thought was fun. It's very brief. We actually didn't even go in enough detail here. Well, you can kind of see it anyways. 32-year-old male with pyelonephritis who does okay. This is like that classic alpha phenotype. They're not on vasopressors. They get better in a day or two. They go home. Compared to that 76-year-old with heart failure, CKD, they got a fever. They got kind of acute kidney injury. This is that beta phenotype, that old comorbid patient whose inflammatory markers are relatively okay. They probably have some renal dysfunction. And if they get sicker, it's probably related to their underlying comorbidities. Compared to that 58-year-old male, they have pneumonia, they have a high white blood cell count, they're on mechanical ventilation. That's that gamma phenotype, right? That's that phenotype with high inflammatory markers, often lung involvement, who often ends up on mechanical ventilation. And that's compared to the 62-year-old female with urosepsis, that gram-negative bacteremia, that lactates high, they got coagulopathy, right? Liver injury. This is that delta phenotype. They're on vasopressors, the sickest of the sick, highest mortality. So that alpha phenotype, mortality 5%, beta was something like 13%, gamma was something like 15%, and then that delta was something like 33% mortality. Okay, so this study, obviously lots of limitations. It was retrospective, it looked backwards, it was observational. They used kind of electronic health record data. Causality was not established. This was all kind of correlation. There will be future studies on this that'll help us understand if there's causal. Phenotypes are not mutually exclusive or static, right? Do these change or progress over time. This just looked at within 6 hours. At 24 hours, do these phenotypes still stand? All that kind of stuff. And it's not yet integrated into the clinical arena, so this is all food for thought. Future directions, as we said, look at this combined with biomarkers. There's fancy things like transcriptomics, proteomics. All these are being used to phenotype in sepsis. Many of them are not clinically oriented right now, but maybe they will be at some point. Could you combine these clinical phenotypes and find that the proteomics, transcriptomics, or biomarkers also vary based on these clinical phenotypes? Real-time electronic health record-based phenotype alerts. This would be really cool if these phenotypes were validated, if these were real, because it was all on data that we had within 6 hours of presentation. So could we say, oh goodness, this person's got septic shock, but not only that, they're the gamma phenotype. So that's an interesting future possible direction. Targeted therapies is something we talked a lot about. Again, really exciting future direction for targeted therapies. And then at the end of the day, if this was a real thing, could you integrate into sepsis care pathways, resuscitation bundles, all that good stuff? So that is a kind of quick and dirty on sepsis clinical phenotypes based on this trial. There's tons of other trials out there on phenotypes looking again at kind of protein markers, biomarkers, transcriptomics, all sorts of crazy stuff. So if this is something you're interested in, let us know. We're happy to provide you with additional resources or even do future videos on it. But hope you enjoyed that. Subscribe if you liked the podcast, 5 stars. If you enjoyed the video, give us a like. Again, we'll upload some practice questions and study guide to our Patreon page. And we appreciate you. Stay well, keep learning. We'll see you next time.